and this is interesting. As a physician, many women have come to me over time, and they've been getting information from their best friend's sister, or their mom's aunts, relatives, or maybe a coworker. And some of it could be really helpful, and others could be like absolutely ridiculously wrong. And so I think one thing they should realize, it's okay to realize there's a lot of knowledge to be gained here.
This is the Get Healthy 360 podcast, where we discuss topics related to your physical, mental, financial, and spiritual health. Your host is Dr. Kris Ferguson, board certified in anesthesiology and pain management. This podcast is for informational purposes only, and you should consult your primary healthcare provider before making any decisions related to your health. And here's your host, Dr. Kris Ferguson. Oh, one more thing before we start. If you like this episode, please consider rating us 5 stars. We would really appreciate it. Thanks very much.
Welcome to Get Healthy 360. Today we're talking with Dr. Baumgaertel. We're talking about a subject that is often not covered in medical school or medical circles, and it's something that half the population will be going through. We are discussing the very common but often misunderstood condition of menopause. Dr. Baumgaertel wrote a fantastic book, The Menopause Menu. Honest review, because there's no conflict of interest. It's a really easy read. She covers all of menopause and super easy to read. It works really well as a conversation piece, as a coffee table. Christmas is coming. I think it'd make a great Christmas gift, stocking stuffer. And again, great coffee table book. I'm going to hold it up. It even looks like a piece of artwork, really nice cover. So what we will be discussing, because I'm a pain doctor, is things that specifically relate to pain management, but I will highlight some of the chapters in her book as we run through this. So Dr. Baumgaertel, thank you so much for joining us today.
Thanks for having me. I'm really delighted. I see that we're both here in the evening, so we have our spotlights on. But I'm in Seattle, and it's nice to tune in to your show today.
Yep, I'm in Wisconsin and on Central Time, but it is good and dark. So let's start with, can you define menopause and what is it?
Yeah, I think this is a perfect way to start. Let's define it for people, because there's a bit of misconception sometimes. So pre means before. Premenopause is the years before menopause. So you're probably in your 20s or 30s. Peri, things like perimeter, peri means around. So perimenopause is around the time of menopause. So maybe some symptoms are starting, but you're not fully in menopause. You can typically be in your 40s. Menopause, technically, if you still have a uterus, is 12 months without a period. Now, you can have surgical menopause at any age, and that means both ovaries are taken. So basically, your estrogen production is pretty much nil. And then post-menopause, post means after, is basically all the years after menopause. So you could be 65, you could be 95. So anytime after menopause is all post-menopause.
So menopause then, so women should be thinking about menopause around late 30s, early 40s.
Well, that would be that kind of the pre-peri. Premenopause is long before you kind of get into the menopausal years. I think textbook, or, just in terms of statistically the bell curve, 47 to 52 is kind of the average ages. So if you were 40, that would be considered early menopause if you're not menstruating anymore. If you were 59, that's considered pretty late. But 47 to 52 average, 45 probably fine, 55 probably fine. So it's probably about 7 to 10 years where that's typically where menopause happens.
Some fantastic chapters in the book. I will highlight the chapters and then we'll expand on certain chapters because they specifically relate to pain management. But in menopause, you get hot flashes, night sweats, sleep disruption, changing and ending of your periods. And what's great in your book is you have like these fantastic little bullet points. So it's really quick read, and then a couple pages just giving you the details of each of those symptoms. And then you actually have recipes that you can use to moderate those symptoms. So let's talk about vaginal dryness, because that could also cause pain with intercourse. And that, of course, would impact your relationship, etc. So what do you want to expand on the vaginal dryness symptoms?
Yeah, that is actually a biggie. In fact, when you think about menopausal symptoms, the typical ones that you usually think off the top of your head is hot flashes and night sweats. And when you think about a patient in a doctor's office, often there's not enough time to talk about things, or maybe it's embarrassing. And vaginal dryness could be one of those topics that kind of doesn't get addressed, but can really impact the day to day. Vaginal dryness can lead to other things like uncomfortable sex, and so therefore that may change your relationships. It can actually be connected to vaginal and urinary trouble, and so when you think about like the whole pelvic floor area, so it's not just a vaginal issue, but it's a big issue. And I think that it can actually start, vaginal symptoms and vaginal dryness can start before menopause, kind of leading up to, but it also can just like a ton of bricks start after menopause, when the estrogen levels have really kind of petered out to nothing. And when women have a surgical menopause and they have their uterus and both ovaries taken out, it also can kind of start abruptly in that way too. And if it's left untended or uncared for or untreated, it can really not go away and be quite a concern for not just sexual interactions, but for personal health. And boy, not a comfortable situation.
And you have a fantastic recipe on roasted delicata squash in here. And delicata squash is actually my favorite squash. But what is it about squash that's helpful for this particular condition?
Well, back up for a minute. When I chose recipes for this book, and I kind of, 16 chapters, so there's 16 recipes, some were chosen for specific things, like, it could be phytonutrients or phytoestrogens or, components or macronutrients that impact positive change for the symptom, like, for instance, for hot flashes. For this chapter, though, I kind of I flopped around a little bit, and I thought, okay, I'm going to choose something that has maybe some antioxidant properties. I'm also going to choose something really that maybe is mostly water, and so you think about water as being a nutritious and hydrating. So it's not like delicata squash is going to fix your vaginal dryness. That I want to make that perfectly clear. But that really it tells you that there's a lot of playfulness with this book, and that was one of the playful recipe pairings that I used.
Oh, fantastic! And what is your thoughts on hormone replacement therapy?
Wow, do we have 3 hours? Yeah, that's really probably
the shorter version. Well, you can give how much information you want. I know that.
Yeah.
So to phrase this, and you can comment on the.
Sure.
And I understand this is a complicated topic I'm asking you about. So if you can explain the issues with hormone replacement therapy for a lot of these symptoms and what your thoughts are on it.
Yeah. I can talk specifically about vaginal dryness because that would be easier, but I think it's a great question because usually that's really on the forefront of most women's minds. Do I, don't I? I think that there's been an unfortunate history in terms of, you go back into the early 2000s, like 2003, 2004, when the Women's Health Initiative data first came out. Unfortunately, there was some misguided and harmful conclusions that were made. At that point, I remember in my office, literally, women calling, screaming at me on the phone before the computer era, saying, oh, I had to stop my hormones and now I'm going nuts. And these are women who are 65 and 75 and 85, and they've been on hormones forever. And so we did a big disservice to women, we meaning kind of the medical profession. We didn't really understand it. Fast forward to now, hormones, in my opinion, are neither good nor bad. So I think the key here is they need to be tailored to the person, so tailored to the woman. There's some women who absolutely, like, over my dead body, you'll pry the hormone prescription out of my hands. I'm going to be on this forever. And there are other women who say, look, I never, ever want to do hormones. It's not for me. I don't believe in them. And you have everyone in between. And so I think as physicians, we need to listen. We need to honor that. We need to respect choices. And then we need to educate, the pros and the cons and, safety and so forth. So when you think about vaginal dryness, for instance, that is the perfect place to think about hormones, because there's a difference between systemic hormones that affect the entire body, and targeted hormones. Well, if you have you're not doing so bad, but you have vaginal dryness as the biggest concern, well, you can do targeted hormones to that at the vaginal area. There are creams, there are inserts, pellets, there's rings, there are kind of, things that you can put inside the vaginal area that can relieve the dryness, kind of improve the suppleness of the tissue there, and kind of reverse some of the atrophy that happens. And it's not like being on hormones, like the whole body is on hormones. And that's kind of like the perfect scenario, because there's very few contraindications for using vaginal hormones. Even women who've had breast cancer, who may be very concerned about being on hormones, can use, a number of years ago, it would be taboo, but now I think the oncologists are saying, yeah, if it's quality of life issue, let's go ahead and we'll give you some vaginal hormones. So great use for hormones in that area.
I think it's interesting that, like yourself, and then another book I just read by Peter Attia, you're both saying very similar things regarding the women's initiative and that study on hormones. They just painted a very blanket statement when really they should have dissected out the criteria and the studies a little bit better before they came out with their recommendations.
Yeah, and unfortunately, there are many reasons for that. Unfortunately, part of it too was that they used Premarin and Provera. I have it's been years since I last prescribed a woman Premarin or Provera. We have more modern, appropriate kind of bioidentical hormones nowadays, which are far better. And also, the age group they looked at, was older women. So now there's a kind of a consensus data. If you look at the American North American Menopause Society, they just changed their name to the Menopause Society. They absolutely condone the use of hormones, for the most part, up until age 60-ish as being safe. And then beyond 60, there may be some fallout or questions about, studies are ongoing. We need more data. But so that's a huge difference than what we were told back in the early 2000s, which is great. There are always going to be contraindications. If you had blood clots or, cirrhotic liver disease or, embolic strokes, or you have the BRCA gene and genetic, predisposition to cancer, maybe breast cancer, ovarian cancer, and maybe several women in your family have had breast cancer before you. So you have to have hormones prescribed by a physician who's very up on the data and knows you and counsels you about what your personal risks may or may not be. And once you've had that conversation and it's deemed valid to prescribe it, then, I think it's okay to consider hormones for any woman. And again, it comes back to quality of life. If you are miserable, like for instance, not just vaginal dryness, but night sweats, and you're just trashed at night, you're waking up every hour, every half hour, you're drenched, you're frustrated, you're not sleeping, then you're tired, then the next day you have brain fog and you can't concentrate and you're snapping at people. It's not just one night, it's night after night. So it gets back to, well, yes, there are other things that can help those symptoms, but if hormones are going to make a huge difference, then wow, let's not be scared of them. Let's really give the right data to women so they can decide with their doctor.
I think you just made a great point where you talked about how as the woman's hormones are changing, it's affecting your mood, which can then affect not just her, but everyone around her. And as a pain doctor, I've seen that, like, if one person in the family is suffering with a pain condition, it not only affects them, but that spreads throughout the entire family. So the next one of the chapters in your book is also libido. And I think that also would impact the relationship as well. And then if, the couple are not happy, that would impact anyone else in that household, or even if they have kids and then the kids leave, and if mom and dad aren't happy, the kids will be affected as well. So what are your suggestions for libido in this?
Yeah, no, I think that's true. In fact, when I got this book finally published, I realized that my marketing audience wasn't just women going through menopause. It was anyone who knows of someone or lives with someone who's, so of course, men and families, and even older adults who may have children go through menopause. So it really is like, everyone knows someone, right, who's going through menopause. Even if they don't know it for sure, they probably do.
So it's a great Christmas gift also for the dads or the men out there.
That's right. That is so true. But libido, that chapter was fun to write. I think that it's important to remember that just, the hormone equation is not going to solve libido. There's so many factors that go into libido. Again, it could be vaginal dryness, ding, ding, ding. We can help that. It could be energy or fatigue. Now, many things, it's like that's multifactorial. There's so many things that can cause fatigue. It's not just going through menopause, but sleep disruption could be part of it. It could be personal health. So what happens? Menopause, that's a midlife journey. Well, in midlife, maybe you have a chronic illness that's getting worse or that's rearing its head. Maybe there are stresses in your life. It could be your parents have died or are sick, or, there are other kind of contextual things. Well, that is going to impact libido too. So it's not just a hormonal thing. I think I talked a little bit about testosterone in that chapter, a little bit from a guarded perspective, because frankly, I think there's a lot of, dare I say, snake oil salesmen out there. And, the whole pellet industry, don't get me started in that one, as if, testosterone fixes all of your fatigue, men and women. I think that's baloney, and it's not valid use of that hormone. There's definitely a good use of testosterone, especially for men, less so for women. And I think that, again, it's not the panacea. It's not going to fix all of your issues. So I would say I approach libido not from just a hormonal perspective, like, here, take this, it'll fix it, but really just more of a kind of look at all the layers that are involved at impacting libido. The recipe for that chapter was fun. It was from a colleague of mine in California who's a internal medicine, culinary medicine expert, and she had a great recipe for these cocoa. I don't have my glasses on, but these dessert items. So just so people understand, when I wrote each chapter, it's kind of like a fine restaurant menu. And so there's the introduction, and then there's an appetizer, kind of an amuse-bouche, and then there's the entree, which is all the meat of the matter, the information in the chapter. And there's a palate cleanser, which is the recipe, and then dessert is actually kind of like a wild card, or almost like a fun area. So she had a dessert for the palate cleanser, if that makes any sense. I don't know if you found the chapter.
No, I haven't. It's I think for libido, it's a great recipe. It's called Magic Chocolate Truffles.
That was it, yeah. And so those are really fun, and kind of what makes it magic is the ingredients. But cocoa or cocoa bean or cocoa is felt, dark chocolate is felt to maybe be a quasi-aphrodisiac, and so maybe that's where what I kind of paired it up with libido for a reason.
Yeah, and the pictures are fantastic, and it looks like a really straightforward recipe as well.
Say it again.
Oh, it looks like a really straightforward recipe. I think there's 1, 2.
Yeah, and in fact, I think
8 steps. Like, this is very doable.
Half the recipes in my book are barely even recipes. They're like how to assemble something, and like miso soup, really easy. And I think that's the whole point too, is that when you're menopause and you're tired, you don't have time to make all these fancy recipes. So you want something quick and meaningful and nourishing and tasty. Food has to taste good, or I'm not going to do it.
Yeah, it looks like a fantastic recipe, and it would definitely be like a fun, let's make these together kind of meal, or a dessert, I should say.
Yeah.
So then, following the libido, we talked about urinary tract changes. You have a whole chapter on that. You also talk about weight gain during menopause.
Yeah, big subject, pun intended.
Yes.
I actually, before I wrote this book and before I spun off to do my own business, within my own practice, I ran a program, developed and ran a program called Menu for Change, and it was for 7 years. And it was a weight management program, kind of morphed into almost more of a wellness program, really, frankly, which was delightful because it had so many different components to it. naturopathic docs, acupuncturists, nutritionists, exercise physiologists, psychologists. We had support groups, stress management groups, walking clubs, book. I mean, it was really the full gamut. And I loved it because it approached the whole topic of weight management a little differently. Like, to me, diet's a 4-letter word. Everyone's tried a diet, it doesn't work. That's where everyone makes their big money, trying to sell diets. Now, of course, we're in a completely different era with these new medications, originally made for diabetes, that are kind of just really bursting out with different companies making them, and hopefully that stays the course.
What's your thought on those medications?
I'm going to be neutral. I'm not going to be for or against. I have a bit of anxiety about a lot of the side effects. I've personally known people who've, for instance, had a partial small bowel obstruction, needed surgery, and that was a god awful experience. Good thing they survived, and it was a physician. But I also know people who have lost a lot of weight. My worry, and I hope that somebody somewhere proves me wrong, my worry is that these are medications that you can't stop. And that once you stop, like anything, the weight comes back on. You don't reset that, point. And so I hope that there comes a day where there's simpler versions that are accessible to everybody, that are not so expensive, that maybe aren't injections, that people can take very low dose, maybe even once a month to kind of maintain something. But it reminds me that no matter how you approach weight loss, be it a gastric sleeve or Roux-en-Y, big surgery, or a medication, those other fundamental lifestyle behavioral changes have to be in place, or I don't think any of this works. So I kind of get back to not like a mightier, holier than thou, but I get back to more of a holistic perspective. Do you want to have your life under control in a way that's very nurturing and supportive? Do you want to have better sleep? Do you want to have better energy? Do you want to move more and exercise more? Do you want to eat nourishing foods? Those are so key, whether or not you're on a medicine. And I think that really has to be there, in my opinion. I look at people on these medications, and some of them really, they say, well, I eat a bunch of crackers and a piece of cheese, and that's it, I'm full. And I said, wow, so you can never have dinner with your family again. Oh, wow, that's interesting. That doesn't hit me very well. I like to go out to a restaurant. I'm a foodie. I like to eat, and to just sit there and nibble on something because, you're full right away. Maybe that's fantastic for weight management. And we're going to see the impact on cardiovascular disease, chronic illness, diabetes, and so forth. So far be it for me to say that's not good, but there's a sadness in me because that would be a hard way to live. So I don't know. I go back and forth.
My thought would be, if you can't really eat a lot, then it's hard to exercise. Like, you have to maintain a certain caloric intake if you're exercising. If you're cutting your intake, it's going to be really, really hard to exercise. And lots of studies have shown that exercise is really critical to your well-term well-being. Yeah. So speaking of exercise and physical well-being, let's talk about some of the musculoskeletal changes that happen with menopause.
Yeah, I think a lot of women will complain of joint pain. And so kind of bona fide arthritis, probably osteoarthritis. And that could really just be a factor of aging. Again, when you think about menopause, it's midlife, so often late 40s, early 50s and beyond. So osteoporosis is something that really rises to the top. And I think it's really important to know that, post-menopause, those first 5 years. So let's pretend you go through menopause at 52, then 52 through 57. Those first 5 years are key in terms of you have low estrogen levels, you're at much higher risk for developing kind of an accelerated bone density diminishment or osteopenia, which is a precursor of osteoporosis. So it behooves us to learn things that are helpful for our bone health that impact our musculoskeletal system early on. If you already have borderline or you have osteoporosis, that's a time to really jump all over it and making sure you're getting treated. What do we care about? Well, we care about fracture. We want to reduce women's risk for falling or for fracture. So I think about lean muscle mass as well. So when you're going through menopause and estrogen dips and it's a longer time period, you're really at high risk of losing lean muscle mass. So if you haven't developed kind of a good exercise routine, now's the time to really do that, because I think it's going to serve you well, just in terms of feeling good and functioning good, like your joints, but also in terms of preventive, especially when it comes to your bone health.
So can you talk about the magnitude of impact on, say, specifically osteoporosis? And let's back up. So let's talk, for those who don't know, what is osteoporosis and why is preventing osteoporosis a really important thing?
Yeah, so osteoporosis is diminished bone density. So if you think of, something that is more fragile or frail and easier to break, there's a very, very good way to measure or to screen for osteoporosis. It's called a DEXA, basically a bone densitometry or bone density test. A lot of women have had this before. In the typical regions, they look at the lumbar spine and the hip. And if someone has had a lot of trouble with their lumbar spine, like lots of degenerative arthritis, or maybe they've had surgery, then they might use their wrist as an example. But typically the lumbar spine and the hip. And they look at several regions and they can give you a score. It's called a T-score. And that score can tell you if you are close to average or normal bone mineral density for women, or if you're in a negative way, like a T-score of -1 would be like early osteopenia, -2.5 osteoporosis, and beyond that, more minus, even worse. And that kind of gives us a gauge of how likely you might be at risk for fracture. And one thing that's important to know is that over the years, it was clear that not every woman who had bone mineral density loss or osteoporosis had a fracture. I remember patients who fell down a flight of stairs and they had osteoporosis and they never fractured. And then I'd also have someone who maybe had a little osteopenia and they trip over a curb and they break 5 bones. Like, oh my gosh. So very recently, in the past few years, we now have an added measure, and it's called trabecular analysis. So not only can we measure the bone density, we can measure the bone quality, which is fantastic. So the two together give you a much better prediction of whether or not you may be at risk for fracture. And if you are at risk for fracture, then there's lots of things we think about. We think about calcium, we think about vitamin D, we think about your balance, your gait, are you going to be tipping over? What's your core strength and you're able to move? And of course, muscle mass. And then we think about things like medications that may or may not be useful to prevent further bone loss, and certainly might be useful if you've already had a fracture. So lots in a big nutshell there, but a very good topic to think about when you're going through menopause to make sure you're getting screened.
I think when people are younger, they don't think about the preventative habits that they have, like exercise, diet. When they're premenopausal, that all has an impact on when they're menopausal. How much of a change is it then when someone's going through menopause? Like how does their risk increase for osteoporosis, or how does their risk increase for muscle mass? Like how much of a shift is that in menopause?
I think it's going to be different for every woman based perhaps on their nutritional status, comorbidities, which is a word for like, do they have other illnesses, or are they on other medications? Perhaps their heritage. So whether you're perhaps Asian or Caucasian or African American or Latina, I mean, there's a difference in terms of statistical risks. And then just based on your overall kind of physical abilities. And so just because you go through menopause doesn't mean you're going to get osteoporosis. You don't have to live in fear of that. But I think it's having an awareness of, gosh, maybe I should get screened. People who have a long history of cigarette smoking and they quit, yay, but that may have really kind of screwed up their bone health. Folks who have been on prednisone or other kind of steroid medications for long-term asthma or Crohn's or other diseases, yeah, they might be at risk for bone loss and for osteoporosis. Those who may have a genetic predisposition, those who have never drink milk, they hate milk, they have dairy intolerance, and they just, they don't even think about calcium. Maybe they've had decades of hardly any calcium intake. So there's other scenarios, but it kind of has to be in your mind. You have to think about it. And I think you have to get screened for it. Sometimes we sadly in this country, only get screened for things that insurance is going to cover. And usually 65 and older, you get a test. 65 is like the horse is out of the barn. You should be screened long before 65, in my opinion. And hopefully, with your physician at the keyboard, they can think of some appropriate screening codes that will be useful to get it covered, because I think it's just a really valuable tool.
I think it's worth mentioning, if someone wants these tests, they can certainly pay for it out of pocket, assuming they can afford it. So then you talk about in the book about the weight gain, and then it can affect your body image, musculoskeletal changes. There's also often a lot of fatigue with the menopause that we mentioned before. There are skin changes, nail changes, hair changes. How does it affect your mental health?
Oh, great topic. I actually broke up into two sections. There's one on mental health, there's one on stress and kind of life changes. So mental health, I think it's so important, because long before menopause, a woman could have had or could have ongoing issues with depression or with anxiety or with some PTSD or OCD or other things. And so menopause can just kind of add almost insult to injury at a time when maybe you're feeling pretty vulnerable. And then all of a sudden you have these other things that are going on with your body that you're not understanding or you're not liking, and they're impacting you. And so mental health problems can really come out in a way that are really not friendly. I think it's so key to make sure that people really understand that there's someone listening. There is that 988 hotline you can now call for suicide, for folks who are feeling suicidal. There are physicians, therapists, counselors, social workers, mental health providers who are really adept at helping people connect with others or with groups or with medications that can be helpful. So nothing to be embarrassed about, nothing to be kind of shying away from, but it's a time to get medical care for people who really need it. Not to sound too dramatic, but I just really think it's good to make sure people feel permission to get help when they really are not doing well. Different than stress, of course, which is like everything else. It's like it could be menopause in the workplace, may not be fun, or stress because at home, because maybe if you have kids, maybe you're becoming empty nesters, or maybe your parents are old and frail, or maybe you're a caregiver. And so all those things, and maybe you're thinking about retirement, or there's a lot going on in life, often in midlife. And so unfortunately, menopause can just be like, oh, one more thing to deal with.
I think that's a fantastic answer, and it's interesting how one medical condition like menopause, that shift in hormones, can affect so many aspects of someone's life. And then you also talk about chronic disease conditions. Then lastly, this is a big topic, the impact of menopause on cancer risk.
Yeah, so it's the last chapter, and I belong to, or I volunteer at a local organization called Cancer Lifeline. I've been president of the board for a while. I stepped down recently, and I've seen what it means to really give support to families and people who are touched by cancer. As a physician, of course, I've diagnosed so many and helped with treatment. I find that it's helpful to there's so many cancers, I didn't want to list them all in my book, but I focused on several. Especially for women who are going through menopause and are worried, like, what is my risk, or what do I need to be worried about? Well, again, you kind of backpedaling to like what's happening midlife. Well, if you're 50 or maybe even 45, depending, you need to make sure you're getting screened for colon cancer. Menopause is not going to increase that risk. It just reminds us that you might be at that age. Breast cancer, obviously, hopefully it start before age 50. Many people get a baseline at 40, and some people get regular screenings through their 40s, but certainly 50 on annual mammograms is a must. Women who have had pelvic and PAPs over the years often think, I don't have babies anymore, I don't need that. No, you still need to get screened for cervical cancer. Now, fortunately, we have HPV testing, and so if you're negative, then you don't have to go in every year for an annual PAP. Some of this is very dependent on family history and other risks, so I'm pretty kind of oversimplifying it, but getting screening is key. I will mention one thing, and that's about ovarian cancer, which is a horrible cancer, obviously, for anyone who has it or who knows people who've had it. Interestingly, the data are quite surprising to some people when they find out that if you're on birth control pill, oral contraceptive, which has some estrogen in it, that can actually reduce a woman's risk for ovarian cancer. Now, when you're gone through menopause and you're not having periods anymore, you're off birth control pill. Estrogen, if you're on hormone therapy, that doesn't reduce further risk for ovarian cancer. So it's not it's not on the other side helpful. But sadly, of course, ovarian cancer can be hard to diagnose. Often there are symptoms that are very, very common that up front, probably almost every woman has had, change in urinary patterns or pressure or fullness in the pelvis, or maybe some bowel changes, or maybe some, weight changes. So it's, again, I guess I always come back to making sure you're getting screened, get your annual exam. Even if you think you're healthy, go in for your annual, making sure your physician has looked at what are the typical things you should be getting screened for at this age, and stick with it.
No, that's a fantastic answer. Thank you. So this book it's really a great coverage, and it's really informational for all of the aspects of menopause. I'll also emphasize again, it makes a really nice coffee table book. The cover is great, really easy to read. What would you say is something, if you could leave a message for a woman's significant other going through menopause, other than reading the book? Because that would probably be the most helpful thing, because then they could better understand what's going on. If you could leave a message beyond reading the book, what would it be?
Yeah, I would say don't give up. It can be a lengthy journey, not to sound Debbie Downer, but it's not just like your last period's done and then you have some knowledge given, you read something in 6 months, you're good. I mean, it could go on for years and years and years, even more than a decade, in terms of a lot of these symptoms that can be struggling. I think for women, I'll get back to the partner in a minute. For women, it's recognizing that you may feel like you're developing this new wisdom, kind of a new wisdom about your body, how things work, not the way they used to, sadly, but you're adjusting. I think you have to maybe have a sense of humor. It's good to learn to poke fun at yourself and to laugh a few things off. And then, not that you're a teacher, but teach those around you. It could be your partner, your husband, or whomever you're with. There are things that maybe you're not also happy with, just so they know what you're going through. I think back to a different era. So when I was a kid and my mother was going through menopause, no one talked about it. It was like taboo. I'm sure I did not know when she was going through menopause. I don't think anyone would have. Well, nowadays, not that you have to wear all your problems on your sleeve, but it's okay to talk about some of these things. It's okay to relate to others. It doesn't have to be the subject of every conversation, but it's okay to explain what's going on and kind of garner support that way. And then maybe someone will cut you a little slack when you're not yourself. And then also maybe you realize, oh, that didn't really come out right. Maybe I should rephrase. So it's a learning curve for everyone. And again, if you look at it a little playfully, that's helpful. And when I realized I had this book written for women, I thought, ooh, this is going to be helpful for men too, because then they can understand what their partner's going through.
And you have great menus, so that's definitely a full book of activities you can do together to make the dishes together, for the woman and her partner. What is something that you think women are most surprised about menopause? Is there a theme that seems to be coming up of, oh, I didn't expect this, or is it just a little bit of everything?
That's a really good question. I think, and this is interesting, as a physician, many women have come to me over time, and they've been getting information from their best friend's sister, or their mom's aunts, relatives, or maybe a coworker. And some of it could be really helpful, and others could be like absolutely ridiculously wrong. And so I think one thing they should realize, it's okay to realize there's a lot of knowledge to be gained here. If you haven't gone through menopause, you really won't know the nuances. There's a lot of overlap, so a lot of common themes, but then it's very individual, very individual. So the other thing that might be a surprise is it can be a lot longer than anyone wishes or desires. So just because the period stopped, you think, oh, I'm home free now, I'm good. It's been 12 months without a period, I'm done. No, it's like sometimes things can snowball. And so recognizing you just have to cool your jets and breathe, pause, and say, hey, this is a life phase. This is something that every woman goes through. And it's not just you. It's not just your hardships. This is it. This is part of living. And so I think that approach makes things a little easier. Perhaps, at least it did for me.
So there's premenopause, there's menopause, and there's postmenopause. How is the
pre, peri, and yeah.
So pre, peri, and post?
Yeah.
Okay. So the postmenopause, how is that different than the transition, or is it different?
Yeah, good question. I would say postmenopause. This is where maybe that's a good common misconception. I've met many women who are like 65 or 70. Like, I went through that long time ago, honey. That's not me. Like, oh yeah, you still have the consequences from having gone through menopause. I'm like, oh, you're right. So having gone through menopause, hormones, estrogen levels, kind of now very minimal, and you're of course you're not having periods anymore. And maybe you conquer the night sweats and the hot flashes, and they're just kind of trivial here and there, but they're really hardly an issue. But then you enter into a phase where the very fact you are in postmenopause, oh yeah, I remember the vaginal dryness. Oh yeah, I remember their urinary problems. Oh yeah, maybe the osteoporosis risk. So, these things kind of keep going on as a consequence of having been through menopause. So I think it's important to kind of keep those at the forefront.
And I think it's useful for everyone to keep in mind that there's not a lot of information that you get in medical school or residency, depending on what your residency is in, on menopause. So I would say it's almost more of a specialized topic.
Yeah,
I think I
it's
cover
interesting.
it for a day. Like, there's not a lot.
No, I just did a book group recently with 10 women. It was really nice. The woman had 10 of her friends over at her house, and they had some delicious food and some drinks. And we kind of talked round robin for about an hour. And they asked me a lot of questions. One woman, I remember, very pointedly said, I don't think any of my doctors, and they told me this, had ever had any training about menopause. And so they just kind of dismissed me, not because they were mean, but because they really didn't know what I was talking about. And she felt almost gaslit or whatever the past tense of gaslight is. And she felt frustrated. And then she turned to alternative kind of medicine to help her. Now, right or wrong, that helped her. That should be a wake-up call, I think, for anyone who is helping women, which is many, many, many physicians, to understand that maybe it behooves them to learn a little more about this transition. I think, there's so much in terms of support and groups and educated people and books for women who are trying to conceive, or for fertility, or having babies, or having just had a baby and they're postpartum. There's so much body of information, energy, and effort and support there. There's not the same amount and intensity and excitement as women go through menopause. It's like almost like don't talk about it. So I think now we're just seeing a lot of this come out. I don't know about you, but you can't, look at the Washington Post or New York Times or any kind of publication nowadays. There's always something about menopause. It could be menopause in the workplace or just menopause in general. So it's neat that it's coming into the spotlight and people are talking about it a lot more. I think that gave me really a kind of hope that as I wrote my book, it would really be available to a wider audience and people that could benefit from it. Because you're right. I think back to my training. I got my MD 30 years ago. I don't remember, except for one rotation through GYN, and I think I delivered 2 babies or helped to deliver 2 babies, and remember seeing a couple PAPs. I don't think even in that rotation I had any exposure to menopause at all, period. So I think it's overdue that all of us who help women get a little bit of a better knowledge base. But good news is that it's more accessible to everyone in general.
I think you've really done a fantastic job of making this really accessible, and you've taken a lot of actually pretty much all of the medical jargon out. So it's very readable, and some fantastic fun recipes that are really easy to make. Like, most of the steps are just a handful of steps. So they're really quick and looks like very delicious recipe. And I will also mention that you are open to doing virtual book clubs, and then you can answer questions about menopause with a virtual book club. So anyone across really anywhere can contact you, and your contact information will be in the show notes. And then I would suggest that if you're having a book club, the least you could do is have everyone in the book club buy a book. But you are open to virtual book clubs, which would be a fun thing to do.
Yeah, I'm new at this. This is the first time I've ever written a book, but I'm really jazzed because my first in-person book group was great, and I think I can't drive everywhere across country, so it would be really cool if people have like 8 or 10 friends they want to have at their place in a party. Maybe I Zoom in. So it's kind of a work in progress, but I'm really looking forward to more of these events.
A little wine and book club would be fun with a celebrity guest. So, any closing thoughts on menopause, or anything you wish I should have asked, or anything you want people to really take away from this interview?
Oh, not really. I just think it's great that we get a chance to talk about these things. And there's such a lot of depth of experience and different experiences that women have. I think also it's important for women who are pre-menopause, like, oh, that's a way far away from me, to know that it's great to get some of this information early on, and then kind of makes that path a little simpler. And I think knowledge is power. So if you know some of these things and you're in a conversation with someone, then you can also chat about it in a way that's helpful to them. And you're not just replicating something you saw on Dr. Google, which is never right.
That is true. All right, Dr. Baumgaertel, thank you so much for taking time for this interview. And again, I would advocate for anyone, if you're interested, to reach out to you. All her contact information on social media will be available in the podcast notes, so you can reach out to her and have a book club. And again, it makes a great stocking stuffer or coffee table book. So thank you all.
Thank you for having me.
Thank you for listening. If you enjoyed this podcast, please subscribe and visit the Get Healthy 360 Facebook page. We are always looking for feedback and new story ideas. Thanks again, and see you next time.